Hi, everyone. It's a pleasure to be here today to talk about the Extraordinary Baby Study. This study is a natural history study of health and development in infants with the prenatal diagnosis of XXY, XYY, or trisomy X. I'm presenting on behalf of our team in Colorado, which involves a large team of very dedicated professionals and research coordinators, as well as Dr. Judy Ross's team at Nemours Health. So to begin, I want to talk a little bit about just an overview of the study itself, and then I'll talk about medical findings in the first year of life and developmental findings, and then what we've learned about the prenatal experience and parenting stress in infancy will be presented by Susan Howell. She is a genetic counselor and led these aspects of the study. Dr. Shanley Davis and Dr. Jennifer Janis will also join us for the Q&A, and so we will all be there to answer questions. There's other sessions very related and presenting results from this study, and they are there's a developmental delay session this afternoon at 6. Another session by Dr. Davis and myself about other medical conditions. We'll be expanding on some of the information related to the first year of life. And then Dr. Louderman will also present on temperament on Saturday. Okay, so as many of you know, within the same X and Y variation, XXY, trisomy X, XYY, XXYY, there's a lot of individual variability. There's variability in the neurodevelopmental and psychological features. There's variability in the physical and medical findings. And this variability brings up a lot of questions related to outcomes. Where will my child fall on this spectrum of variability? It's very challenging as a professional to provide care and counseling around this question because there's also so much overlap with the general population, and we don't know the predictors of that variability. We have lots of research studies to date that provide us a lot of really good and solid information about different features that individuals with X and Y variations are at risk for. But all of the studies, or many of them, either contain incomplete data around what these features are, or there's bias in where the samples came from. They came from clinical samples, they came from research recruitment, and there's not a lot of big studies that show us what happens with individuals who are diagnosed in the prenatal period and what are those predictors of the variability. There's been a really big change in the past 10 years in the prenatal genetic practices, testing for the genetics of the baby. And now there's a maternal blood test that can identify the DNA fragments of the baby and identify X and Y variations, as well as many other genetic disorders. Prior to NIPS, the proportion of individuals with the X and Y variations that were identified in the prenatal period was very small. It was about less than 10% in each group of all of those, all expected cases. But with the advent of NIPS, this sliver is significantly growing into a much larger piece of the pie, and we are identifying and we'll expect that we'll continue to identify larger and larger proportions of our X and Y variation populations in the prenatal period. We actually estimate that the diagnosis rate will increase up to 10 times. And in the United States, that means 50,000 babies being born in 5 years with a prenatal diagnosis of X and Y variation. This leads to both a lot of need and as well as a lot of opportunity for learning more about our X and Y patient population. So in terms of needs, with this growing proportion, we definitely need more information for genetic counselors and providers in terms of how to counsel families with the prenatal diagnosis and how to care for infants once they're born. And then it also presents us with a lot of opportunity, as we'll have a large cohort of newborns with the prenatal diagnosis, and this will allow us to do updated studies. We call them prospective studies that follow infants from birth. These prospective studies are very strong in terms of giving us information, as there's less bias than we used to have from research samples that were identified only from the clinic or from research populations. And it gives us opportunity to learn about neurodevelopmental profiles from birth, about medical profiles and medical features from birth, and the predictors of these outcomes. It also allows us to understand the family experience so that we can improve genetic counseling and just overall improve medical and developmental care. So is born the Extraordinary Baby Study, which was initially funded in 2017 by the NIH, the National Institute of Child Health and Human Development. And this is a really complicated diagram, but in summary, it's like our big model. So the first grant period, which was from 2017 to 2023, was here. And then we were just refunded in a renewal period through 2028. And so this first grant period went to early childhood. This one's going to go into early school age. And then hopefully we're going to be able to follow patients all the way through adolescence and adulthood. And what we're doing is we're taking those with a prenatal diagnosis of a trisomy, and then we're looking at all these potential risk or protective factors, socioeconomic status, location, resources, parent IQ and background, family genetics, mosaicism, prematurity, birth weight, all sorts of different medical factors, and then other things, exposures, parenting stress, community supports, developmental therapies, hormone levels, like what are all the things that may be related to some of these outcomes later on. And then we looked, and will be continuing to look at outcomes across all the different domains of health and development in early childhood, in school age, now that we're going to be able to follow this cohort all the way up through school age. And then hopefully as we get older or as the cohort gets older and we get more and more funding, then into adolescence and in adulthood to look at, what are the predictors over here of later adult outcomes being good, so we can promote those things. What are the predictors of outcomes being, less good or challenging? And can we do something along the way to change those trajectories of those who are struggling and having challenges? So the aims of the study are to describe the natural history of neurodevelopment, medical problems, and early testicular and ovarian function in infants with sex chromosome trisomy, to establish a biobank, which means we have blood samples that has DNA and serum, and we have urine samples, we have stool samples, and then we can do studies on the genetics and DNA associations with these different outcomes later, to look at these risk factors like I talked about of the different outcomes, and then to also look at some of our primary care developmental screening tools to see if the screening tools that our pediatricians are currently using are good enough to identify the developmental delays that may occur in some individuals with the different X and Y variations. Okay, so this is a big summary slide and it looks really busy, but basically we enroll individuals at 2 months, 6 months, or 12 months, but they have to be enrolled before 12 months of age. And then the study visits have been at 18 months, 2 years, 3 years, 4 years, 5 years, and then we'll continue 6, 7, 8, 9, 10, in our new period. And we do a lot of data collection, like I talked about before. We also, when they come for in-person visits, there's a combination of virtual visits and in-person visits. Then we do developmental testing. We do the ADOS, which is social skills and autism screening. We do questionnaires on behavior and all sorts of different aspects. We do the developmental screening questionnaires. And then we do all sorts of physical and other type of assessments as well. The study's done in 2 locations, the Nemours location led by Dr. Judy Ross and our location in Colorado. And so in terms of the results, I'm going to start sharing a little bit. Our current cohort is 298 patients, which is very cool. We might be at 300 by now, but 298. The majority of our cohort is XXY. Those are the ones who have been identified more frequently. And we're not 100% sure why there's such a big discrepancy, but we're working on trying to understand that. We have 33 infants and young children now with XYY and 66 with trisomy X. And so this is a great accomplishment and very appreciative of all of those families out there from all over the place who have participated in the study. So over here is our cohort of all of our individuals broken down by which X and Y variation they have. And I want to spend a little bit of time talking about the tetrasomy group, which is XXYY syndrome or XXXY syndrome. And in this group, there's 9 individuals. And so the grant specified that they had to have a prenatal sex chromosome trisomy identification, which is one of these three, where they have three chromosomes. But actually, there were a lot of times where the test was discordant, or it didn't match when the postnatal testing was done on the infant. And so we do have a group of patients with the tetrasomies who prenatally were identified to have XXY, postnatally XXYY, or XX, XY. And this is a really important group to follow because there's even less information about the natural history and prenatally identified cases of these. So we felt like, we can't exclude those who didn't end up with a prenatal diagnosis of a trisomy. And, and this is, even though it's a small number, it's a really valuable number. And, we hope this number grows as well over time. And so this talks about, we don't have to go through every detail, but what age they enrolled at, how many study visits we've done. Look at that, 947. Now we're up to over 1,000. Then how few people have withdrawn from the study, 3.3%, because I think what we're doing is so valuable and there's so little information out there by knowledgeable professionals. And so the families really appreciate participating in the study, how many biosamples we have in the repository, and then just the race and ethnicity variations. I will tell you that overall underrepresented by race, ethnicity, or income status in the poverty level is pretty good, 31%, 32% overall in the study, but it's never good enough, right? Because we really want to make sure we're representing everybody. And our study sample does have a higher number of individuals who have higher incomes and higher levels of education. And that skews results towards, higher levels of functioning. So we want to make sure we're having a broader representation in our recruitment sample in our new study. And then they come from all over the US, like you can see here. So we're going to spend a lot of time talking about results from, the first couple years of life. And I just want to explain that even though we've been doing the study for 5 years, recruitment and seeing patients and all of that takes some time. And so what you see on this graph is here's patient number 1 up here, and he started at 0 or, within the first year of life. And then by now, he's 6.5 years old. And so here's study patient number 2, 3, 4, 5. So their age here, and then where they were at the end of the first study period. And then the light blue is how old they're going to be by the end of the second study period. And so what you can see here is that, if you're looking to describe all of your 1 and 2 year olds, you have to wait until you have them all. Right. And so now we are where, these patients have been. This was 270 when we made this graph, but and so this is really is showing you. So for us to really describe all 4-year-olds, we're going to have to wait until everyone has aged into a few years, into this new study before we're going to have enough data for that. So there's always going to be a lag. So we have a big enough study sample size because we don't want to describe just this group of 5-year-olds. We want to describe all the 5-year-olds. So first, I want to tell you about an analysis we did on medical problems in the first year of life. This was presented at a poster at the ACMG meeting in March and presented by Susan Howell and was selected as a top poster at the meeting, which was very great for our team and to spread the word about our study. This analysis included 252 infants with SCT. You can see the different numbers here. And first, we looked at physical exam findings that we found in these infants. And we found many different ones at different levels, but the ones I want to talk about are these first few at the top. Epicanthal folds were the most common, as well as hypertelorism. These are both findings in the eyes where you can see slight little pieces of skin that kind of extend down in the middle of the eye. They're very small and don't cause any problems with vision. And then mild hypertelorism, which is a little bit of wide set eyes. Again, not strikingly wide set, such that there is the individuals look dysmorphic or have any atypical facies, but they're just subtle features that we notice and honestly don't really cause any problems. Clinodactyly is the curving of the fifth finger, and that also is very mild and present in about half of our cohort, but also doesn't cause any problems in terms of functional use of the hands. The other one we saw was torticollis, which is seen in this baby with a little bit of a head tilt to one side or preferential looking to one side. And this can be treated easily with stretching exercises and positioning of the baby, as well as occasionally physical therapy, and very occasionally the need for a helmet if there's such preferential looking that the head shape becomes not round, or what we call plagiocephaly. We also did evaluation of those individuals when they'd had either echocardiogram or kidney ultrasound. About 22% had an ASD, which is a septal defect in the top chambers of the heart, or a VSD in the bottom chambers, and 23% had kidney differences. These were all very mild, and most resolved with time. Others that hadn't resolved by a year of age were being followed, and only one child had required surgery for their kidney and one for their heart. The entire population had not been imaged, and so we don't know what the proportion of this is if you actually do echocardiogram or kidney ultrasound on everyone, and that's a need of follow-up in the future as well for our studies. We also recommend from this that individuals with the prenatal diagnosis have an echocardiogram and a kidney ultrasound after birth, just to make sure everything is okay and anything identified can be monitored. We also identified problems with breastfeeding in 50% of our sample. There was a small group that didn't attempt breastfeeding, but in those that did, about half of the sample had challenges with breastfeeding. This was primarily with latch, and many benefited from lactation support. When there were problems with breastfeeding, we did see some challenges with failure to thrive, with increased or earlier introduction of formula, and then with frenotomy or frenulectomy, which is a clipping of the tongue, which is sometimes done due to breastfeeding challenges or to tongue tie, and we really need to better understand if this was actually helpful in the breastfeeding difficulties in those where it was performed. We recommend from these results that just the awareness that breastfeeding problems are common, that families receive breastfeeding lactation consultation and support if they do want to breastfeed. And then many individuals also had pumped breast milk delivered by bottle or delivered infants formulas, which were very safe and obviously well accepted as a substitute. And then finally, in the first year of life, we looked at medical problems. Generally, all of these medical problems that are common in babies and little kids, otitis media, which is ear infections, bronchiolitis, or respiratory infections, these all occurred at the same rate as the general population. So they were not more frequent than in the general population, but they did tend to be hospitalized more often. We had 12% of our babies that were hospitalized most of the time for respiratory concerns related to bronchiolitis. So while they're getting sick at the same frequency, we do feel like some of them get a little bit sicker and require hospitalization. Other things that were very common were GI diagnoses, reflux, failure to thrive, constipation, as well as allergies, asthma, and eczema that we saw in 55%, and then some other medical conditions over here. Now I want to move on and talk about our genetic testing results. These are genetic tests of all of the trisomies combined. There were not differences between the three groups, and so we put them all together for this study. The Bailey is the test that we use to evaluate development. The scores that are typical are in the red box, go from 7 to 13. 10 is average. And we looked at the different domains of development listed here on the bottom at different ages, 6 months, 12 months, 24, and 36 months. And what you can see here on average, the mean scores in our population for cognitive skills, for example, were all well within the normal range and all very close to the mean of the general population. The stars down here indicate where our sample was lower than the general population. So while you see here for expressive language, for example, the mean scores are still, again, the average of the group is still within the normal range, but statistically it's lower than average. And you can see that some of our error bars do extend down here into what would be called the borderline or the delayed range. So we also saw differences in the first 24 months of life related to gross motor skills development as well. I want to share this graph, because what we did was we then plotted all the babies we had over time to make a developmental growth curve. So this is a developmental growth curve for the cognitive domain, and basically the black lines are X and Y babies, and the red lines are the general population. And what you can see here is there's perfect overlap between our infants with X and Y variations and the general population, showing, again, in a different way, no difference in that developmental trajectory related to cognitive scores. This is an example, though, in contrast, related to our language scores. So here, again, the black is our X and Y babies, developmental scores over time, and then the red is the general population. So again, still a lot of overlap, but you can see that there's a little bit of a shift down from the top of our general population, and also another proportion down here where there's a lag and lower scores, and those are our individuals with the most significant speech delays, although again, fairly mild in terms of language delays overall. So we also looked at early intervention therapies, and this is early intervention therapies anytime within the first 3 years of life. So for all of the individuals that we had seen through 3 years of age, about 60% or 58% had received any early intervention therapy at some point during that time. And then if you look down here, about 40% had received speech or physical therapy, 22% had received occupational therapy. The importance of this is that, people receive therapy for different reasons, sometimes in response to a developmental delay, and sometimes because there's a risk for developmental delay, they receive them proactively. They don't necessarily have a delay, but they're receiving proactive therapies. So our next steps are really at looking at the differences in trajectories between those who receive the therapies proactively versus reactively as well. We also looked at the Ages and Stages questionnaire as a screening measure, the developmental screening measure that pediatricians would use in their office, and asked, are the screening questionnaires administered by these offices enough to pick up the delays in the X and Y variations? And we compared these ASQ scores with our Bailey, which was direct developmental testing. And what we want to see is that sensitivity of a good screening questionnaire is 0.8. And what we saw was at the 6-month range, it was only 0.16 to 0.5. At 12 months of age, it was 0.1. There was one good domain, 0.9 in the gross motor area. But overall, what we conclude from this is that these questionnaires are not good overall for the types of developmental differences we see early on in the X and Y variations in our population that's at risk for delays. They're meant for the general population that is, not an at-risk population. And so basically, we recommend that individuals have a direct developmental assessment, either by a developmental peds team, an early childhood team, a child psychologist, in the first year of life at 6 to 9 months, and then again at 15 to 18 or 24 to 30 months of age. So now I want to introduce Susan Howell, our genetic counselor, who's going to talk about 2 projects that we've done. One is the family experience with the prenatal diagnosis of trisomy X. This is an example project that we'll expand upon in our next grant period for all of the variations. And so I think the data are very applicable to everybody, all the different populations. And then talk about parenting stress in the first year of life after the baby is born.
Another aspect of our research that we've done around the prenatal experience was interviewing 10 families for thematic analysis around the parental experience or the parenting experience in raising a daughter with trisomy X and reflecting on their own journey. And the themes that we identified through this research were in kind of 4 categories. So the diagnostic experience was a theme that families would often reflect on and talk about. In talking about the diagnostic experience, the 2 kind of sub-themes of the what we learned from families was that their experience had been poor in delivery and learning about their diagnosis, whether it was the lack of available information or that, again, the provider was unaware or not well informed of the diagnosis, having generalized statements that were provided to the family that were really not specific to the individual or the family, as well as the diagnostic experience reflected poor timing. So often families would report really bad experiences around getting a call while they were at work or on results right before a holiday weekend where they'd have to wait an extended period of time in order to talk to the provider about the diagnosis, and then needing to wait to meet with a genetic counselor as well. So there was a lot of distress around both the poor delivery as well as the timing of the diagnosis that they experienced. Another theme that we learned was more of the journey emotionally that families went through, both at the time of diagnosis and the journey being that, going from sadness and disappointment and devastation to more feelings of hope and optimism, and then back to feelings of anxiety and worry. So there was really this inconsistency of emotions that would go back and forth in families that they would describe at the time of their diagnosis. And we asked families to also reflect on their present feelings of emotions toward their daughters. And while they still endorsed some aspects of anxiety and worry, as many parents do, they also reflected a lot more optimism. So families would say things like they were in awe of her, or had a lot of happiness and love and hope for their daughter. They felt very reassured as she grew and developed over time, and they got to know her. So this emotional journey of experiencing the diagnosis over time, both from at the time of diagnosis as well as at present, really changed with families. And they described and talked about that a lot. The third aspect that we heard about from themes in interviewing our parents of daughters with trisomy X included the theme of uncertainty. And we hear this very universally in all of our trisomies and all the participants that we've worked with, as well as clinical patients, is that this prenatal diagnosis is laden with feelings of significant uncertainty. A lot of that uncertainty is often attributed to the variability that can be associated with the diagnosis. There's a lot of variability from a medical aspect, from a developmental aspect, from a learning and cognitive aspect that we can see, and that variability then leads to feelings of uncertainty naturally, in that we don't know what the future holds, and that uncertainty being a common emotion that parents experienced in raising their daughters. They also felt a lot of uncertainty and described a lot of uncertainty in regard to disclosure, talking about disclosing the diagnosis to family friends or to the child, how to do it, when to do it, wanting to protect their child's privacy and autonomy. So they talked a lot about uncertainty around the topic of disclosure as well. And then the final theme that really came to attention in our interviews was the mechanisms of coping. So how families would navigate the uncertainty in coping mechanisms. Some families endorsed a lot of research, that they would read a lot of information that was published before the baby was born or shortly after. Some families endorsed coping strategies of reaching out and connecting with other individuals, especially, connected through AXYS is a great resource for this. But families would feel like they needed the support, not only of other families with trisomy X, but then also of family and friends that were close to them, so that they, as they were going through the emotional journey, had that connection for support and helping them cope through that as well. And then the last kind of coping mechanism that was really described was more that of reframing. So taking the information that had led to a lot of significant emotions at the time of diagnosis and trying to reframe it, and that they felt empowered by the information, and understanding that by having that diagnosis, they felt empowered to be able to be proactive, sort of like what Dr. Tartaglia was talking about in regard to getting interventions, that having that information ahead of time gives families the opportunity to be proactive in seeking out resources, whether it be lactation consultants for breastfeeding or speech therapy, and understanding early intervention in your community. So this center diagram really is taken from the publication that we have currently under review. We're hoping gets accepted in the near future. And it really describes how families go through this emotional journey of uncertainty to coping throughout the diagnostic experience and then into early childhood. The last study that, from a genetic counseling perspective, that I wanted to highlight really addresses parenting stress. And I think, this has been one of the more positive aspects that we've learned from the research that we've done in the beginning stages of our study. But this study looked at the Parent Stress Index, which is a standardized measure of parenting stress, and the domains of stress around the child, stress specific to the parent, total stress, and then life stress. So these are standardized questions that are validated. And we interviewed 237 participants for the purpose of this study that was presented last spring at the American College of Medical Genetics meeting. And in looking at the parenting stress at the 2-month period, the 6-month period, and the 12-month period, you can see that the dotted line in this chart represents the generalized mean for the population. And so that's the average population. And at all 3 time points, our cohort was defined as being statistically significantly lower in parenting stress for our babies that are in the study. And we don't really know why, if this is a reflection of the fact that families will often describe their babies as being easy babies, or if it's a reflection of the fact that they experience so much stress in getting the prenatal diagnosis that the reassurance of having a healthy, happy baby after birth had really reframed in and of itself the stress that they felt in parenting a child. But it's really important to recognize that the parenting stress compared to the normal population or the typical population is lower in this cohort as well. Okay, and then I'm going to let Dr. Tartaglia take it from here.
So thank you, everyone, for listening. We're now going to take some questions. I just want to acknowledge our fantastic team that's worked very hard on this study at both sites, our funders from the NIH, and we're happy to take some questions.